Good afternoon, everybody. Correction, Senior Medical Liaison. Jordan is the Senior Director at DINE, so some confusion. Thank you, everybody. Exciting to be here today. What a good time to be in Canada, right? With the World Series going on, and it's great to be back in Toronto. I used to live in Montreal, so it's wonderful to be back up north. And so, what a wonderful time for the Duchenne for 30 years, right? It's always a milestone to be here. So I'll begin by presenting some data today on our Explore 44 trial. And this is a trial that is designed for boys that are amenable to exon 44 skipping. And Dr. McAdam did explain what exon skipping is. And Jordan, thank you for also teeing that up, right? So I'm just going to settle in that. And so no, thank you guys. You guys just made my job easy, and I'll just flow through my presentation. So the Zoda is now we have an open label extension, and I will present both the top line and functional data. Before we move on, we just want to share appreciation for everybody, the participants, the families. We know what is a heavy lift, right? Being part of a trial, and their commitment and continued contribution is very, very more important to us. So, disclaimer, what I'm going to share today is an investigational product. We cannot draw any conclusions based on efficacy or safety so far. We are just giving this information because it's for educational purpose, and we cannot make any treatment decisions on this data. We did a phase 1/2 study. The phase 1 part was to evaluate the safety and the dosing of Delzoda, and the phase 2 part, which I'm going to share to you today, we're looking at the long-term dosing of this product, and it is an investigational product. It has not been approved by any regulatory agency as of now. So who are we in Avidity? We have this vision, right, that we want to improve the lives of everybody that is affected by neuromuscular conditions, and that is by revolutionizing RNA therapeutics and how we deliver it. This is what we have come up with. We have a platform that is known as the antibody oligonucleotide conjugate. So to my right is the monoclonal antibody, and I want you to think about this like a GPS signal that takes you to where you want to go to. So what we do now is we have conjugated therapies, which we've leveraged this platform in not just Duchenne, but in DM1 and FSHD, where we conjugate our therapies onto the monoclonal antibody, and as a very prolific signal, has given us the ability to deliver to skeletal muscle, and that's what we call the antibody oligonucleotide conjugate platform. So, and as Jordan mentioned, we are leveraging the transferrin receptor. It is highly expressed in muscle cells. So what we do is we have our component, the AOC, bind onto the transferrin receptor, and then we leverage the body's processes to dissociate the payload from the antibody oligonucleotide, the antibody, and then it translocates to the nucleus. And since we're investigating those boys that are amenable to exon 44, what it does, and what Dr. McAdam explained, it then allows us to skip over 44. Therefore, we are making what we think it should be a shortened form and functional form of our dystrophin. So this is just to show you an exhaustive list of anybody that falls within this range might be amenable to exon 44. So please, if you can contact your provider to have more information about where you sit at in that, in this list of amenability to exon 44. So let's get into the meat and potatoes of this presentation. So Explore 44 is actually the trial that we started, and this was a randomized double-blind placebo control. We had 2 cohorts in this trial. We had a 5 mg per kg that was dosed every 6 weeks, and the reason we dosed every 6 weeks is because we could leverage our platform that gives us sustained delivery into the muscle. That's why we could dose every 6 weeks rather than every week compared to what's the marketplace right now. And then we had a cohort of 10 mg per kg that was dosed every 8 weeks. And here we require biopsy because we had to look at the dystrophin, and then it was placebo controlled. So we had 9 patients that were on active drug and 7 that were on placebo arm. And then everybody then rolled over to open label extension. And as Dr. McAllen mentioned, you get to a point of the trial where everybody transitioned over from the placebo arm to receive active drug. So right now, everybody is on active drug, and they are all at 5 mg per kg and being dosed every 6 weeks. And what we did was we added additional participants because the cohort was smaller, so we added 60 more participants in this cohort with no biopsy. So right now we have 39 participants. We have a broad age range. We had 7 to 27, and then we had a mixture of both ambulatory and non-ambulatory patients, and over 90% of the boys in this study were on steroids. Right off the bat, is phase 1/2 safety is our main concern, and we can see that currently right now it's safe. We have one participant that discontinued due to hypersensitivity, but then everybody else is still in the trial. Some of the common treatment emergent events that we observed was upper respiratory tract diarrhea, fall, backache, and pain, and which is all related to when you have an exon-skipping drug. These are some of the adverse events that you would experience. So just to rearrange you what we're trying to do, you have different forms of dystrophin. At the top, we have the natural occurring dystrophin. That's what we're looking at. And what we are trying to produce is what's in the middle, what is close to a near form of your natural occurring dystrophin. And below, you can see what is being produced when you do a gene therapy. So when we look at dystrophin, that's why we collected biopsy. And remember, we had 2 cohorts, right? We are looking at the blue and teal bar compared to the open bars. And we could see that the placebo arm compared to our 2 treatment arms, we had a really good signal of dystrophin production. A picture is worth more than 1,000 words. So we are like, great. If you produce dystrophin, what are you looking at? Because we don't want to produce dystrophin and not realize that it is at the membrane where it is impactful. So we looked at this staining, and this is called immunofluorescence staining. At the top bar, we could see that at baseline before treatment, we have very little positive staining, or that is red. If we look below, we can appreciate that we have now a good amount of dystrophin that is located around the membrane or the sarcolemma. That is where we want it to be. And this correlates to the amount of dystrophin that we are seeing when we do look at the protein level to my left. So we are all, most of the families here are appreciative of what creatine kinase is, and Dr. McAdam mentioned that is what, the biomarker for diagnosis. We looked at these patients, and if we orient you to the blue or the teal dots, we're looking at the patients that were on active arm, and we can appreciate that once you get those patients on therapy, over time, we're looking at the study months in the x-axis. Over time, we see that the creatine kinase is actively controlled till we get to a point where it is close to upper limit of normal. And the gray bars the gray graph is the boys that were on placebo, which means they did not receive active drug. But then what we're realizing is once we transition everybody to open label extension, that we give everybody active drug, we can really appreciate that there is a control and a decline of CK to the level that the boys that were on active drug were at. And right now we are over 16 months, and we can confidently say that almost 50% of our participants on the trial right now, after 1 year, do have CK that is close to upper limit of normal. So because all our boys were on, we had the placebo arm, and everybody now has transitioned over to open label extension, we're looking at functional changes. We went into the whole data platform and used the PRO-DMD natural history study. What we did here is we matched the boys in that trial to the corresponding boys from this trial. So we found 22 boys that were part of this trial. We matched the age, we matched a lot of the characteristics. Here we're looking at 4-stair climb, the time that takes you to climb 4 stairs, time that takes you to do 10-meter walk run test, and time to rise from the floor. And we also look at the NSAA score. I just want to highlight that from this, we could see that the boys that are part of the ZODA, our trial, they use more time to complete this test, this time function test. Hence, they are at a disadvantage when we look at these boys compared to the natural history study. But then, what is exciting is that, well, let me just share a little bit. So we're looking at the time that it takes to complete this test. So if you use more time, it means that you're worsening, and if you use less time, it means there's functional improvement. And what we realize is that when we compare these boys, looking at all these time function tests, to the natural history study, be it 4-stair climb, 10-meter walk run test, the time that it takes to rise from the floor, or the the pool, which is the upper function, we can appreciate that the boys that were on Delzota are now averaging less time to complete those time function tests compared to the boys that were on the natural history study where there is no intervention. We also went a step further to look at the NSAA score. And what this will measure as is a functional mobility test, and it is a composite of a lot of skills. And thank you, Sarah, for doing that. I'm just going to skip over this. I'm not going to spend time to explain it. But then we are looking at different score type. We have a 2, 1, and 0, which is how fast you can, or what you use to complete these tests. So what we see in our trial when you compare to natural history study is that these boys are stable. They are not decreasing in score. So we think at 1 year they are stable. So it's a positive outlook from this result so far. Where we are right now, I look into the future. With FDA, we are in conversation to have approval or to do file the BLA Q1 of next year, that's 2026. And also, we are not going to stop there. We're looking into other exon skippers that we think we can leverage the technology that we have so that the boys that are amenable to, for example, exon 45 skipping can also benefit from what we have right now. And with that, if you want to stay in touch with us to follow up and see what we're doing, please, you can scan the QR code. But I would like to thank everybody for your attention and thank you all for your individual contributions. Thank you.